I'd like you to imagine you're 80 years old. You've been living in a residential home for 10 months. You don't want to interact with people because you're sore. You're reliant on others to help you mobilize in a wheelchair. You're sad and you're tired all the time. This is how I remember one resident. Let's call him Jim. Jim was an outgoing person, but over a 6-month period, he'd had repeated urinary tract infections that required either the use of antibiotics in the care home or hospital admission. He was in pain, isolated, immobile, and he struggled to find the will to carry on with life. What if it didn't need to be like this? Think about how it could be if you're living in a care home where staff and residents are supported to introduce innovation that matters to them, brings hope, and improves quality of life for people like Jim. My name's Katie, a clinician by background. This is my job, and I love it. Urinary tract infections, UTIs, are one of the leading causes for care home residents to be admitted to hospital. The elderly are more susceptible to them for many reasons. A reduction in thirst, multiple medications that they take, fear of incontinence if they drink more, cognitive impairment, or they may be unable to move to get themselves a drink or speak to say they're thirsty. Many care home residents, when admitted to hospital, are dehydrated. Not so long ago, in the southeast region of England, hospital admissions for UTIs were noted to be high in care and nursing home residents. I joined together with a pharmacist and staff from 3 residential and 1 nursing home. Our aim was to reduce hospital admissions for UTIs by 5% from the previous year. But we didn't just want to stop there. We were on a mission. We wanted to reduce the number of residents requiring antibiotics for UTI and improve their well-being. To begin, we needed to understand the scale of the problem. Working with staff in care homes, we gathered data on every resident who had a UTI. We used stickers as simple identifiers. A red sticker on a chart indicated if a resident had had a UTI requiring hospital admission. An orange sticker was a UTI requiring antibiotics in the care home. And a green sticker was an incident-free day. Staff were shocked to learn that on average, every 9 days, a resident was diagnosed with a UTI. Things had to change. Empowered by this intelligence and our desire to discover what could improve the lives of the elderly in their final years, we got curious. Have you ever stopped to ask yourself why you do something the way you do? That's where we started. Why do we only offer tea or coffee? Why is it important to stay hydrated? Why is it important to identify the early signs of a UTI developing? And why is the accurate diagnosis of a UTI crucial? Without the why, the solutions remain in darkness. But as we looked together at each why, it was like slivers of light, starting to illuminate what the next direction was. These solutions are designed, owned, and implemented by staff who know their residents' routine. They know the rhythm of the service. They know what will make a difference. What they need is permission to speak and someone to say, "I hear you." Together, we introduced staff training and a structured drinks round. The staff training covered anatomy of the renal system, risk of dehydration in the elderly, how to identify the early signs of a UTI developing, and medicines and their body, how they affect the body. The structured drinks round took place 7 times a day and offered an array of drinks. How did we know what drinks to offer? Simple. We asked the residents. We held tea tasting sessions, had flavor of the month, mocktail of the week. We themed drinks around celebratory events like Valentine's, sporting occasions, and royal weddings. Activities coordinators worked with staff and residents to make it something to look forward to. They noticed when a resident had a preference, which enabled those with cognitive impairment to have the drink they liked in the cup they liked. Some homes had cool drink stations where residents could help themselves. Others had events with family and friends. They were innovative and cost-neutral. There were no large, colourful frameworks, just a burst of colour, fun, and thirst-quenching solutions. Over an 18-month period, staff and residents exceeded their set target. UTI admissions to hospital reduced by 36%. UTIs requiring antibiotics in the care home reduced by 58%. And the average days between UTIs went from 1 every 9 days to a sustained improvement of 1 every 80 days. And Jim, following the introduction of the staff training and structured drinks round, he was more mobile. He walked with a stick. He had the desire again to be involved in activities and be part of the community. He remained free of UTIs. He had a quality of life. One final thought. What changed that quality of life for Jim? Could it have been that we asked him? Could it have been that staff who know the rhythm of the service, who know their residents best, were involved at the start and supported to introduce a change that had lasting impact?